Hi, this is Jan Probst again, back to talk to you some more about rural. Now, if you're watching this video, you've presumably already read the PowerPoint, and you've presumably already seen the previous video with some descriptions of what constitutes rural in a real technical sense. Here, we're going to discuss a little bit more what the situation of rural Americans, and particularly minority rural Americans, is at present, and provide you both with some graphic pictures in terms of maps and some true graphs that just illustrate some of the disparities and inequities that we will be documenting. Just to give you a sneak preview of the conclusions that will come from this lecture, we're going to document the ways in which rural residents experience a lifetime of reduced access to care, both financial access and literally geographic access. And as a way of illustrating minority health disparities, we're also going to point to trends among rural minority populations. Although we typically think of, for example, African American populations as living in big cities, in truth, there are large rural minority populations across every racial ethnic group, and the disparities they experience in rural America are frequently much more severe even than those in the inner city. Being a professor, I always have to define my terms. We talk about disparities and inequities as if they were interchangeable, but to be more precise, what I will be talking about are inequities, which are differences in the health status or distribution of health determinants between different population groups that are not logical. It is, for example, a disparity if my children finish faster in a race than I do because I'm an old professor and they're healthy young adults. That is a disparity, but not an inequity. When certain populations have reduced access to care in their community, that is an inequity. When we talk about rural, I'm going to point out that we're talking not just about geography, but a context in which people live, which includes the services available to them, their opportunities for education and self-care, and the culture that surrounds them. And finally, I want to clarify that race, as we are talking about it, is a social construct. Race is something that we say distinguishes people, but which may have little or no biological basis. Since we are recording here in South Carolina, I'll start with the African Americans and their presence in rural America. As you can see, the African American pattern of settlement largely follows that of the Old South, and you can see how many of the rural counties have significant, perhaps in some cases even majority populations that are African American. It's a regional phenomenon, but a large region. A similar pattern is found for Hispanic residents in rural America. Traditional patterns of Texas, which after all was part of Mexico before it was part of the U.S., New Mexico, and those areas. But you'll also note that there are significant Hispanic presence in other farming communities all across the U.S., including the upper Northwest. Finally, I'd like to point out the population that most of us consider most rural, the people who were here before we were, American Indians and Alaska Natives. Much of this population still lives in rural areas, particularly in Oklahoma, New Mexico, and states in the upper West. One of the first challenges for rural America is inequities in service availability. Rural America is marked by fewer providers, much less availability of good health insurance, and in consequence, rural residents experience delayed care. All three of those access problems, few providers, little insurance, and delayed care, are most prevalent in counties that are called health professions shortage areas. Compounding the disparity that I mentioned earlier for minority residents, rural counties that have high proportions of minorities are more likely to be full or partial health professions shortage areas than are other counties. Think back to the slides we looked at earlier regarding where rural minority residents live. As we noted before, the rural African American population is concentrated in the South. In counties where the rural African American population is above the median for the U.S., the simultaneous shortages of health professionals are more common. Notice how that map lights up in its darkest color. Where you have lots of African Americans, you have few healthcare providers. The same sad story of inequities in service availability pertain to the Hispanic population. Although the location is different, the story is the same. Where you have more than the median Hispanic population, in rural areas, you are also likely to have fewer health service professionals, fewer doctors, fewer nurses, fewer dentists, fewer psychiatrists to deal with the problems these populations face. The same song in yet another tune. Wherever you have a concentration of minority populations in rural America, you are likely to have health profession shortage areas. People do not locate, when they expect to make a living, in areas where much of the population may not be able to support them. Although the today in this slide no longer applies, I want you to remember where rural minority populations were, and then look at this slide regarding the percent of housing units that lack complete plumbing facilities. Yes, that's right, I said that lack complete plumbing facilities. In rural areas today, although the percentage is still very, very small, there are still people who rely for sanitation on outhouses. In the previous slides, we talked about health profession shortage areas, areas where the ratio of providers, persons like physicians and nurses, to the number of people in the community falls below national standards. However, even when the doctor is present, financial access might not be there. Without the magic of green, people may not be able to get in to see the few providers who are there. And no, Obamacare isn't going to fix it, because as you'll see, rural minority populations unfortunately live in places that are not really slated to change in the near future. This is a somewhat complicated slide that you can study at your leisure, but it does reflect two important points. First, looking just at white folks, let's notice how the proportion who are uninsured steadily rises in rural areas and is much higher than it is in the dark black inner cities. Of course, the proportion of uninsured persons is always lowest in the golden suburbs, which is why they get little stars. But notice that rural effect going on. Little stair steps for the white population, little stair steps for the black population. There are two kinds of disparities in America today. The race ones that we're all familiar with, and there are also disparities associated with rural populations, carefully illustrated in this slide. This slide illustrates some of the material from the previous slide, but over time. Rural residents have always had a strong likelihood of lacking health insurance, and it has always been worse for minority residents than for white residents. I said earlier that the Affordable Care Act was not a fix for rural minorities. The next three slides illustrate this. If you'll remember where rural minority populations were, in the South, in the Southwest, and in the Northwest. Look at this slide. This is where working age adults are likely to be poor and uninsured. Here are the states offering Medicaid expansion. As you can see, they are generally not the states with high minority populations. And in fact, most rural minorities live in non-expansion states. There is no quick answer to the problem of minority disparities in financial access to care. Takeaway here is just what it says. Rural populations, and in particular rural minority populations, lag behind their urban brethren with regard to financial access to care. Why is just money important? Because in this day and age, money to get you into the doctor affects how sick you are, how much time you can put in at work, and in your bigger community, the money available affects whether or not your doctor or nurse will stay there. Did you ever ignore that check oil light till it was too long? You can do the same thing with your health, and the proportion of persons who say they delayed care that they thought they needed increased steadily during the Great Recession. No great surprise there, and I'll just show you a few pictures that illustrate exactly what happened and what that meant for rural populations. Approximately between, say, 11 and 18% of adults say that they have delayed getting care even though they thought they needed it. Again, there is a golden area, at least for white and Hispanic respondents in the suburbs, and in the inner city and in rural areas, people are more likely to report delaying care. As you would expect, if people delay care, they're more likely to have gone a full year without ever having seen a doctor. That behavior pattern is most common among our Hispanic Americans. One of the things to think about, however, is in rural areas, if people aren't visiting the doctor and have no way to pay them, how does the doctor stay there? And of course, the cruelest outcome is early death. This is from a piece of my own research showing that both white populations who live in rural and black populations, but particularly those who live in rural, are more likely to die in a given period of time than are urban white adults of the same age. Rural populations have challenges reaching a provider, but they still have the same sorts of health problems. This slide illustrates the proportion of working-age adults who report being only in fair or poor health. As you can see, the proportion of both white and black adults who report that they are in such poor health increases the more rural the place where they live is. If you don't see the doctor and you report that you're in poor health, what might happen? One thing that might happen, and that again, as you can see, that happens increasingly as the population becomes more rural, at least for white and black persons, is that people report activity limitations, things that they should do but can't do. One of the problems that rural public health planners face is what I call the Mayberry picture. For those of you who aren't old enough or who did not waste your youth watching old shows on TV, Mayberry is the mythical town in North Carolina where Sheriff Andy Griffith took care of everything and everybody knew everybody and no problems were very terribly serious.
The Andy Griffith Show, starring Andy Griffith, with Ronnie Howard, also starring Don Knotts. Brought to you.
Unfortunately, that simply isn't true. The entire U.S. is highly connected, and HIV is as much of a problem in rural areas as it is in urban areas, with some exceptions. And in some areas, rural HIV is becoming more of a problem than urban HIV. While the great number of persons who are HIV positive live in urban America, the proportion of persons who are HIV positive and thus living with HIV or AIDS per 100,000 is greater in rural counties than in urban. In 2009, South Carolina had the distinction of being the only state with a greater prevalence of HIV in rural than in urban counties. By 2010, that had increased to 2 states, Florida and South Carolina. I'm using HIV as one example of an urban problem that isn't restricted to urban, but this is a really important and potentially growing issue. HIV is no longer, if it ever was, a disease of intellectuals. It is a disease that tracks very closely with poverty, and in this country, poverty tracks very closely with minority status. Thus, HIV rates in counties that are poor, in counties that have a high minority population, have been increasing. Look at this picture for a moment, particularly the dark counties, the dark garnet, which represents rural counties. Where is HIV high? Got it in one. It's high in those same counties that lit up when we illustrated areas that had high minority presence and that were health profession shortage areas. But I have another point to make. Let's look at the next slide. This slide displays HIV prevalence by rurality in 2010. Do you see the changes? You probably don't, so I'll help you out. This map illustrates in somewhat more readable detail what's been going on in rural America. A county that is white has too few cases of HIV to be reportable. One that's red is below the national median. One that's dark red is above the national median. Rural counties have been flipping, popping from white or below the median to pink, flopping from pink to red as they go from below to above the national median. This change has been taking place all across rural America. This slide, again taking HIV as an example, shows in microcosm what happens when providers aren't available. Ryan White providers get special subsidies to take care of persons with HIV, and because they see a lot of such patients, are likely to be the best quality provider. Notice how far residents in these 2 states would have to travel to get to the nearest, and in fact only, HIV care provider in their state. How long would it take you to drive 268 miles? Summing up, this very brief lecture has pointed out some of the inequities in service availability in rural areas that have fewer providers and less financial access to care. But it's talked about that second challenge as well, that behavioral health issues are the same or greater in rural as in urban areas. Which means that we're now to challenge number 3. How do we change things? How do we make it so that rural America, and in fact Americans of any stripe, color, residence, don't suffer from inappropriate disparities? That's your assignment because you're students and you're the future. Finding the answers is your job. The Accountable Care Act, as we've noted, really doesn't solve everything. But we desperately need something. We need to take what is frequently called upstream action, action where we look into the social determinants of health. How did rural communities or minority communities become so distressed? What is needed to improve health and improve the availability of healthcare services in these areas? We've got some resources that will help you, but if you'll look at your discussion section on Blackboard, this is now your question to answer. And here's some good places to start looking for an answer. No copying, but lots and lots of numbers. Thanks so much for your attention. This is Jan Probst again. If you want more information about the work our center does, our website is listed here. Thanks.